Okay, in this video, we're going to be doing a review for the midterm. This is over hypersensitivity, immunodeficiency, and autoimmunity. There's about 50 slides that I'm going to be going through here, and we will discuss this and get you better prepared for your test coming up. So the first one that we're going to discuss is hypersensitivity. So there is actually 4 different types of hypersensitivity, which we're going to go through each one and have a better understanding of each type. So type 1 hypersensitivity causes a basic allergic reaction. That is mediated by type IgE. And this causes inflammation due to mast cell granulation. And when we're thinking of type 1, we're thinking of like rashes and super itchiness, more like worsening symptoms, such as like systemic symptoms could be causing wheezing. And it's really important that during this type 1, this is a most dangerous form, would be an anaphylactic reaction. And that can also cause hypotension and then also severe bronchoconstriction. So the main thing that we would do to treat this would be epinephrine. So type 2 hypersensitivity, this causes a cytotoxic reaction. This is tissue specific. So such as like thyroid tissue, or like Graves' disease, like a hyperthyroidism, that could be a couple different things that you could think of with that. This is where the macrophages are primarily effector cells that are involved in this. So this could also be incompatible blood type. An example would be like having a severe transfusion reaction. Maybe somebody was given their type B and they were given type A, or AB positive, blood. So this could be caused by a severe transfusion reaction. And for type 2, again, this is where the immune system produces autoantibodies that target and bind, such as Graves' disease. This is where they would target and bind to the thyroid stimulating hormone on the thyroid cells. And then the autoantibody binding, this is where the binding stimulates the thyroid gland to produce and release excessive thyroid hormones, such as like T3 and T4. So Graves' disease, we think of hyperthyroidism with this, and this is causing an overproduction of thyroid hormones. And when we think of hyperthyroidism as Graves' disease, we're thinking of that rapid heartbeat, that tachycardia, weight loss. They're super skinny. They can't tolerate any type of heat. They have intolerance to heat, and they're very nervous. And then they also do have those bulging eyes as well. Unlike other type 2 hypersensitivity reactions, Graves' disease does not typically involve direct cell destruction, though complement activation or phagocytosis. Instead, the autoantibodies overstimulate cell function, leading to excessive hormone production. So there is key characteristics of Graves' disease as a type 2 reaction. So this would be autoantibody mediated. This is caused by the IgG autoantibodies targeting the TSH receptors. They're inflammatory, not cytotoxic, unlike other type 2 reactions that cause cell lysis. Graves' disease involves over cell simulation. So remember, it's an overabundance of those thyroid hormones. So like we already talked about, symptoms would be that hyperthyroidism, such as increased metabolism, they're sweating, they're tremors, and then the bulging eyes, which is called the exothalamus. So now we're going to talk about type 3 hypersensitivity. This causes immune complex mediated This is hypersensitivity, where immune responses in which antigen antibody complexes, such as immune complexes, form in the blood and deposit in various tissues. So this is triggered when soluble antigens, such as like foreign proteins, drugs, microbial components, combined with autoantibodies, and this is the IgG or IgM, to form immune complexes. Hypersensitivity type 3 can lead to inflammation and tissue damage, and this can cause issues. Common sites of deposition include, or deposition include, to the kidneys, lungs, skin, joints, leading to inflammation and damage in these areas. So when we're thinking about joints and lungs and skin and this hypersensitivity reaction, we can already kind of figure out what kind of issues that this person might be having. So type 2 is organ specific, and type 3 is not organ specific. So the autoantibody binds to the antigen on the cell surface, which is organ specific. Type 3 is not organ specific, and this is where the autobody binds soluble antigens outside the cell surface. So type 3 examples would be rheumatoid arthritis. This is where antigen antibodies are deposited in the joints. And then systemic lupus erythematosus, which is SLE. This is very closely related to autoimmunity antigen antibody deposits in organs that cause tissue damage. So we talked about how type 3 can cause joint issues, and we're talking about rheumatoid arthritis being an example, and then a systemic lupus erythematosus. So for systemic lupus hypersensitivity reactions, this is causing an inflammatory response. This is an autoimmune disorder primarily classified as a type 3 hypersensitivity reaction. It is characterized by the formation of immune complexes that circulate in the bloodstream and deposit in various tissues. This can cause widespread tissue damage in organs such as the kidneys, skin, joints, and blood vessels. There can be some systemic lupus flare-ups. That could be an episode where symptoms worsen or new symptoms appear, often triggered by factors such as stress, infections, sunlight. We think of like UV exposure, hormonal changes, or certain medications. These flare-ups can be and vary from mild to severe. And symptoms could include, again, joint pain, fatigue, skin rashes, kidney issues, fever, and chest pain. And then they can also be managed and prevented by avoiding known triggers, which is wearing sunscreen to avoid the UV exposure, managing your stress levels, and avoiding certain medications. So again, some of those medications could be NSAIDs, which is that non-steroidal anti-inflammatory drugs, or your NSAIDs otherwise, to manage mild symptoms such as just their general joint pain and inflammation. Corticosteroids, that would be used to control inflammation during flare-ups, but minimized for long-term use due to its side effects. Immunosuppressive agents, medications like methotrexate or azapirin, to reduce immune activity to prevent further tissue damage. Antimalarials such as hydroxychloroquine. This is commonly used to manage skin and joint symptoms and to help prevent flare-ups. And then biologics, which is belithium, BAM, target specific immune pathways to control disease activity, especially in cases resistant to other treatments. So some lifestyle and support examples would be regular monitoring. This would include frequent checkups to monitor organ function, especially kidney health. Again, that sun protection, wearing sunscreen and protective clothing to avoid triggering skin flares. And then healthy lifestyles such as balanced diet, adequate rest, stress management, regular low impact exercise to reduce symptom severity and maintain overall health. Autoimmunity, that general term used to describe when an individual's immune system reacts against antigens on the tissue of other members of the same species. So some examples could be neonatal disease, where the maternal immune system becomes sensitized against antigens expressed by the fetus. That could be like transplant rejection or transfusion reaction. So some blood transfusion reactions in the newborn would be that hemolytic disease of the newborn that occurs when a pregnant woman has antibodies against the Rh antigen present on the red blood cells of her fetus. And then organ transplant rejection, that would just be when the T cells and antibodies attack the graft, causing inflammation and tissue damage. And then we have hypersensitivity type 4. That causes the delayed response. It does not involve antigen-antibody complexes like type 1, type 2, and type 3. Type 4 is T cell mediated, and a great example would just be poison ivy. So differentiating between a rash of type 1 versus a type 4 reaction. So there are some similarities and some definite differences. A type 1 is mediated hypersensitivity reaction, termed atopic dermatitis, which are usually characterized by widely distributed lesions. So type 4 is contact dermatitis, which is a delayed hypersensitivity, consists of lesions only at the site of contact with the allergen. So I think of this as if somebody is like allergic to metals, they maybe have like a pair of earrings in that maybe don't have, they have nickel in them, or maybe they are wearing like a type of ring that's maybe causing some rash. So that would be contact dermatitis. It's contact where the source is at. So their ears are going to get red and itchy and inflamed, and same with around their ring finger from where that's at. It's not going to be systemic. It's not going to be throughout their body. It's only going to be at the point of contact. So that's what we think of type 4. It's only at the point of contact, just as like contact dermatitis or atopic dermatitis. So the key determinant is the timing of the rash. So type 1 we know is immediate, right? That's if you're eating, that's your rash, your anaphylactic type of reaction, bee sting, anything like that, eating shellfish, type 1. And type 4 is that delayed. So you can have poison ivy. You can come into contact with poison ivy maybe a day or two later. That's when your rash appears. A rash in type 4 is non-severe in cases of contact dermatitis. That would just be treated with a topical corticosteroid. That would be, you wouldn't need to have epinephrine or antihistamines with that, because epinephrine, of course, as we talked about in type 1, is only for anaphylactic type of reactions. And then type 4 doesn't involve any of that, so antibiotics or anything like that are not appropriate. You might need some cream, some specialized cream for poison ivy rash for type 4, but you wouldn't need anything else. So again, just a quick review of that 4 types again. Type 1 is that IgE antibodies. They use the mast cells, and a great example of that, again, would be anaphylaxis, allergic rhinitis. Type 2 mechanism is the IgG or IgM. It binds to the cells, and it affects tissue-specific and it is can cause hemolytic anemia. Type 3 is immune complexes. Again, that is IgG and IgM as well. And that can cause systemic lupus. And then type 4, remember, is just T cell mediated. And that can be like contact dermatitis or poison ivy. So we have a case study here. So type 1, a patient, 24 years old woman, experiences sneezing, runny nose, and itchy eyes every spring. Her trigger is exposure to the pollen. Her immune system produces IgE antibodies against pollen antigens. Management would be histamines and allergic avoidance to help control symptoms. So the case would be hay fever, right? That's a type 1 allergic rhinitis. So type 1 hypersensitivity reactions involve the rapid IgE-mediated response to allergens. And these are typically within minutes of exposure. So again, in this circumstances, she started having sneezing, runny nose, itchy, watery eyes, which happened immediately to the pollen exposure. Case study for type 2 hypersensitivity would be cytotoxic. This is a hemolytic disease of the newborn. So the patient is a newborn, has jaundice and anemia shortly after birth. The trigger is maternal antibodies against the Rh antigen on the baby's red blood cells. So the mother was Rh negative, produced an antibody Rh antibodies during a previous pregnancy with an Rh positive baby. In this pregnancy, these antibodies actually cross the placenta and attach to the baby's Rh positive red blood cells. This is what caused the hemolytic disease of the newborn. So what do we have to do? These reactions, again, are characterized by IgG or IgM, and this led to antibody-mediated targeting of the cell surface, which led to cell destruction, which is hallmark of type 2 hypersensitivity. And then type 3 hypersensitivity would be hypersensitivity post-streptococcal glomerulonephritis. So a 10-year-old boy presents with swelling, blood in urine, and high blood pressure a few weeks after recovering from strep throat. This trigger is the streptococcal antigens forming immune complexes with antibodies. The mechanism is the immune complexes circulate and deposit in the glomeruli of the kidneys, leading to inflammation and kidney damage through complement activation and recruitment of immune cells. The management is supportive care, blood pressure management, and monitoring kidney function, because we know that this causes immune complexes. So the rationale is hypersensitivity reactions involve immune complexes, right, that deposit into the cell, and it can cause localized tissue inflammation and damage. And then type 4, case study would be a 30-year-old man develops a rash, itchy rash with blisters on his arms 48 hours after hiking. So the trigger would be contact with that euceryl oil from the poison ivy plants. Again, this could be a delayed response. This involves the T cells, and of course, topical corticosteroids to relieve symptoms, along with washing that affected area. Okay, so now we're going to talk about immunodeficiency. Most primarily immune deficiency are the result of a single gene defect. Something is lacking with the immune system itself. For example, like a B lymphocyte deficiency is one of the most severe forms of a primary immunodeficiency. Primary immunodeficiency is inherited. Just think of primary, you can't change this. It's inherited or a congenital disorder of the immune system. This is present at birth, though sometimes it might not be diagnosed until later of life. And then severe combined immunodeficiency affects both T and B cells. Some treatment might be managed with immunoglobulin replacement therapy, antibodies, or bone marrow transplants. And then secondary immunodeficiency. This is from complication of some other psychological condition or disease. So secondary immunodeficiency, this is afterwards. This is something that has caused this immunodeficiency to happen, such as like malnutrition is one of the most common causes worldwide. Pregnancy, eating disorders, or for example, a patient who has HIV gets pneumocytosis carni. This is caused by a weakening due to external factors other than genetic mutations. So primary is genetic, inherited, and secondary is weakened due to external factors. So secondary immunodeficiency is brought on by infections such as medical treatments or other environmental factors that can include infections, medications, chronic illnesses, and malnutrition. So some infections could be HIV or AIDS, which is a really great, well-known cause of a secondary immunodeficiency. Medications such as immunosuppressive drugs, corticosteroids, chemotherapy, all of these can weaken the immune system. And then chronic diseases such as diabetes, CKD, and other types of cancers can also impair immune function. And then, of course, malnutrition, which we just learned is one of the most common types of secondary immunodeficiency. But malnutrition actually causes a lack of essential nutrients, and that can reduce the immune cell functions. So the onset is typically develops after exposure to the causative factor, and that can be happening in any stage of life. And then the treatment for secondary immunodeficiency would just be focusing on managing or eliminating the underlying causes. So is it an antiviral therapy for HIV? Is it nutritional support? What does this patient need? Do we need to reduce the immunosuppressive medications that may be causing this secondary immunodeficiency? We know that primary immunodeficiency is typically genetic and lifelong, while secondary immunodeficiency is acquired from external factors that may be reversible depending on its cause. So that's important to know. Common variable immunodeficiency, that's more characterized by like a defect in antibody production. And then this can cause increased susceptibility to infections. That can also lead to a defect in antibody production. So some key features of common variable immunodeficiencies would be impaired autobody responses. This could be an increased frequency of infections, particularly respiratory tract infections, chronic diarrhea, gastrointestinal issues, things like that. So common variable immunodeficiency is one of the most prevalent forms of primary immunodeficiency. It's characterized by a defect in antibody production. It can also lead to an increased susceptibility to infections that's particularly due to encapsulated bacteria and certain viruses. So some key features, again, of the common variable immunodeficiency would be individuals with common variable immunodeficiency have low levels of immunoglobulins. And then their body has difficulty producing antibodies in response to infections and vaccines, which can lead to inadequate immune responses. And so remember, common variable immunodeficiency is a prevalent form of primary. So it's genetic, it's inherited. Some symptoms of common variable immunodeficiency can be increased frequency of infections, like we said, particularly of the respiratory tract, chronic diarrhea, and gastro issues. This can also appear later in childhood or early adulthood. this disease may be diagnosed in people of any age, including those diagnosed even in their 30s or 40s. Diagnosis is basically based on clinical history, low levels of immunoglobulins in the blood, and poor responses to vaccine. So the management in this would be immunoglobulin replacement therapy. This could either be IV or subcutaneous. Antibiotics such as prophylactic antibiotics may be used to prevent infections, especially in individuals with recurrent infections. Management of complications. This would be treatment for associated autoimmune disorders or chronic infections as needed. And then monitoring just for regular follow-ups to monitor for any more exacerbation of infections and adjust the therapy as necessary. Their prognosis with appropriate management, many individuals can lead relatively normal lives, although they may remain at increased risk for infections and some complications. So some types of vaccines would be live automated vaccines. This is conjugated in severe immunocompromised individuals. So we think of people that can't receive those people are live vaccines. We always think of live vaccines. Nobody that has any issues with immune systems or if they're immune compromised. This is due to the risk of causing a disease, includes MMR, there's measles, mumps, rubella, chickenpox, yellow fever, varicella. Inactivated vaccines. These vaccines are typically safe for immunocompromised individuals as they do not contain live pathogens. Some of these would be the polio, hepatitis A and B, and then the flu vaccine, which is make sure that that's inactivated for the flu vaccine. Some mRNA vaccines. These are generally safe and effective, such as the COVID-19, if people are going to get that, would fit that category. And then herd immunity considerations. So vaccinating close contacts of immunocompromised individuals, especially with live vaccines, can provide indirect protection. So a case study would be a 34-year-old female who is a kidney transplant recipient, currently takes immunosuppressive medications to prevent organ rejection. She has a history of recurrent urinary tract infections and has been advised to stay up to date on vaccinations. She is due for her annual flu vaccine and is also considering receiving the COVID-19 vaccine for protection against ongoing pandemic. She has previously received all childhood vaccines, including the inactivated polio and hepatitis B vaccine. So far, this sounds really good, right? Vaccine decision. Flu vaccine will receive the inactivated influenza vaccine. Live annotated influenza vaccine is contraindicated due to her immunosuppressive state. That's good. The inactivated flu vaccine is safe and effective. Yes, it is. COVID-19 vaccine. She will receive the mRNA COVID-19 vaccine, either Pfizer or Moderna. And these are recommended for immunocompromised individuals as that they do not contain a live virus. That's good. So why are we doing this? It's safe because it's inactivated flu vaccine. Remember, no live vaccines for immunocompromised individuals. Live vaccines could pose a risk of causing illness, which is critical to avoid in someone taking immunosuppressive medications. So the efficiency of both of these vaccines, such as the inactivated COVID and inactivated influenza, can help provide protection which this patient is at higher risk due to her immunocompromised condition. Staying vaccinated is essential to reduce the likelihood of serious infections, which could complicate her health further. Timing of vaccination schedule to ensure optimal immune response, which will allow the healthcare provider to monitor her condition and adjust her immunosuppressive therapy if necessary and around vaccination schedule. I hope this video has been helpful learning about hypersensitivity, immunodeficiency, and autoimmunity. Until the next video, you're going to do amazing and wonderful and great in your program.